No, it's 12:15. You're around.
You look young.
Yeah, you should write your own.
I have mine. You're okay?
You want one?
I have one in my pocket.
Dr. Healy,
My mom would make me
I will send
talk
everybody a
faster.
presentation with the answers if they would like. And then,
What day was it?
Oh, you got that?
Jose's got the
Did
introduction.
everybody get a pain card? There is a sign-in sheet somewhere around. You need to sign in.
Again, thank you for coming for today's grand round of the sign-in sheet. Somewhere on here, be sure to put your name in. And today we have Jennifer Healy who will talk to us about the conversions to managed symptoms. So, doctor, take it away.
All right. So we may have to talk fast. We don't have like table space, so it makes it a little harder to do the conversions, but we can walk through the steps on the slides for how we do the conversions, and then all the answers are there, so you can go home and practice, because really what you need to do is practice, but this should walk you through some of the conversions. So, which way do is that working? Okay. We can do this. I'm not going to push it. Arrow. Okay, so the session objectives are today to practice performing opioid conversions we're going to go through cases. And we may only get through the first case, but you guys will have access to the second case to walk you through it as well. And to recognize how to appropriately prescribe opioids and identify their side effects, and then learn how opioids can be used in treating pain and non-pain symptoms. And we are going to, I do want to say right at the beginning, because we have in elders in our title, that when you're using opioids in elders, you use the same concepts, except you're going to start slow and go slow. Start low, go slow. So you're going to be very conservative with your starting doses, and you're going to, but the conversions will be the same. And you do need to recognize that sometimes when you have an opioid naive patient, even if they're not elder, that you may need to also start low and go slow.
The handout it mentions that you start PRN, then you start PRN.
Well, we'll talk about that, okay? Definitely. So I gave you guys all a pain card. Did everybody get one? Did you get a pain card? You already have one.
I have one, but
Good extra. They're handy to have in case you need to hand them out. The first thing I want you to look on the side that says treating pain according to severity at the top left-hand corner. There's a ton of information on this card, and we cannot go over every single thing, but I want to point out some really important things about the card. And if you ever have questions, almost all your questions will be answered on here. So when you're talking about treating pain severity, this is the WHO analgesic ladder here at the top left corner. You're going to go with the patient's pain score and their expression of how bad their pain is, whether it's mild, moderate, severe, and this will help you in choosing your starting opioid. Usually if you're moderate or severe, you should be using an opioid to start out with. You should not be using like Tylenol or NSAIDs to start. That does not mean you can't use them as well, but they should not be your starting medicine. The next thing I'd like to point out is that there is a whole section on here for prevention and management of opioid side effects. And we'll go over a little bit of this during the presentation, but it's here in greater detail for you. And there's even a stepwise bowel regimen, which can be very helpful in dealing with patients. Every patient that's on an opioid should be on a bowel regimen. The next thing I want to point out is just when you're assessing patients with pain, and you want to, there's some tools over here like the visual analog scale to help you in your assessments. Our goal today is not to really talk about that, but I want to make sure that you know that it's important that you're assessing the pain and looking into the whole picture before you're treating people. Then on the back side, this is the side that you will use mostly when you're doing opioid conversions. This is the analgesic table for opioids. Everything should, whenever you're doing conversions with opioids, you should always be starting with a 24-hour oral morphine equivalent dose. So you should find out how much they've used in 24 hours of whatever opioid they're on, and then you're going to turn it into a PO morphine equivalent using this table. And we will go through that. There is an opioid conversion equation in the top right-hand corner. A lot of people like to use that. I personally just use stoichiometry because I learned that really well, and I don't have to learn anything else again. Why learn something else when something works? So, do you guys all know stoichiometry? How you cross out your units? This is like basic science stuff. If you don't, you can use this. I don't want to teach you stoichiometry today because that's like a whole thing, but you can use this little opioid conversion equation up in the top right-hand corner. But if you know stoichiometry and you're comfortable with it, why learn something else is my opinion.
Is that the same as dimensional analysis?
I don't think so.
Units and...
I don't think so.
Okay.
I'm not sure, yeah. Okay, so you'll notice that there are the analgesics in the chart and then the equal analgesic doses. So if you just use the chart, if you say parenteral morphine, which says 10, and you're changing to oral morphine, then it's 10 and 30. Now you can do more math just right there and say it's a 3 to 1, right? But everything goes on this 10 to 30, and the whole chart does that way. So if you're saying 3 to 1, but you're using the other numbers below, you need to be careful what you're doing, because if you changed morphine to 3 under the oral listing, but you didn't adjust hydromorphone, and you used a 1.5 parental hydromorphone to 3 oral, then you're going to have a problem, and your calculation's not going to work out. So just make sure you watch your math. Math is a hard thing. So if you're not really good with math, you're not comfortable with it, stay with the numbers that are on here is what I would suggest. Man, it's getting hot.
Yeah.
I'm sorry, I'm going to take off the coat. I'm always cold, so I wore it just for that reason. But sorry, guys, you got to be hotter than me. All right, there is a little portion on here that talks about methadone, and I just wanted to show you that. It is also in the presentation, and we'll talk just a little bit about methadone because that gets a little more complicated. And if we don't have time, that's one of the things that I'm going to probably not go over in detail, because we don't have a lot of time, I'm sorry. This is like a huge topic. So let's start with our case. This is JK, 50-year-old Hispanic woman, metastatic pancreatic cancer, with recent evidence of progression to her lungs, and she's undergoing chemotherapy, and she's in a phase 1 clinical trial. She had an appointment with her oncologist 3 days ago and found this out, but was reassured that her oncologist is actively seeking information about other clinical trials that she can participate in, because she's very interested in continuing treatments if she can. Today, she was admitted to the hospital secondary to severe progressive back pain, and that was going on 2 days. So the day after her appointment started, progressed to the point where it's excruciating. She's no longer able to walk, and she hasn't slept the last 2 nights either. In the emergency room, she received 24 milligrams of IV morphine over 12 hours. She also had an MRI of her spine that was done, and the result is pending. So the admitting team that's admitting to the hospital called you guys to consult as a palliative care team, and they want help with pain management. When you enter the room, she's diaphoretic, tachypnic, holding her left back and hip, and crying out in pain. So this is our first question. What is the most appropriate thing to do at this point? And you choose all that apply. So A is ask the nurse to give additional dose of IV morphine. What do you guys think? B, hold off on additional morphine. For those reasons. Ask JK to describe pain. So go through the location, severity, quality, radiation, exacerbating factors, alleviating factors, several factors, and then also finding out the morphine that she got in the emergency room, did it help? Do you guys think that's probably a good one? And then explore the concept of total pain with the patient.
Medicator.
Ask the nurse to get it and
So what's our consensus for answers? Choose more than one.
A and C.
A and C. Okay, that's exact. I totally agree with that. A and C. Okay, so the reason being, well, I'm sorry, I went a little fast, but the reason being, it's on this one. So why is it important? Because you need to recognize there's a pain crisis going on and you treat it appropriately with IV medications. There are times when you may need to use subcutaneous or oral routes, like in home hospice. And so you do that until you can get an IV or get to an inpatient unit so that you can start treating that. But you won't just hold off because you don't have anything else. You do what you have to, that's the point. And then it's really important to get a focused history and physical exam. And sometimes you won't be able to get that until you give them some more pain medicine. You know this lady had IV morphine, was tolerating it well, and so you can give her some more so that you can talk to her. Okay, and these are our incorrect answers. You guys can have the presentation if you want, and you can go over them more in depth if you like. But I'm not going to go through them because what's more important is the correct answers. Okay, it's important to know why not. I want to just say with total pain, I think it's very important. It's just in a pain crisis, you always have to get their physical pain under control before you start exploring those things. Because when someone is in that much physical pain, they're not actually able to express or talk about their emotional things, which really can be playing a big part, or psychosocial things that can be playing a big part of their pain. But in the pain crisis, it's the physical pain that's really causing the majority of the crisis, I should say. So I did want to talk just a little bit about total pain, which I think is very important. Again, the physical pain, social, emotional, and spiritual. Do you guys know what have you heard of total pain before? I know the fellows have. Yeah. Has anybody not heard of total pain? I just think it's really important because when you're treating someone with pain, there are other things that they can express as physical pain. So they may be having, especially, this is just my opinion and what I've seen in practice though, is men or someone who has really severe, fast happening cancer or something, terminal illness. They can have a lot of total pain that they also have physical pain, and they say, like, the whole body hurts and blah, and all this. And they do have like one place, like, yeah, but it's my side that hurts the most, and you treat that, but their whole body still hurts, and their pain's never really under control. This is what you need to start thinking of. So social pain, and I'll just let you guys kind of look over them a little bit. These are just examples. We have emotional pain. Spiritual pain. And then physical pain as well, which we're going to talk mostly about today. Okay. It's important to know the difference between acute pain, chronic pain, because you're going to treat them differently. Acute pain, your goal would be to get closer to not just tolerating, but treating it so that it's gone if you can. Chronic pain, you have to really establish the goals with the person, that they understand that because it's chronic pain, you cannot, they cannot be sleepy all the time and not feel pain. They have to live their life. And so your goal is to restore maximal function, to give them a better quality of life, but they'll have to live with a certain level of pain. And you can negotiate with them to help decide what that level actually is. So there are the different types of physical pain. We have nociceptive versus neuropathic. On the nociceptive side, we have somatic and visceral, and then on the neuropathic side, we have the continuous type of pain, and then the chronic lancinating or paroxysmal, which we see probably more in diabetics and with neuropathic pain and others as well. So nociceptive, somatic pain, skin, muscle, or bone, aching, throbbing, stabbing, pressure. Those are all ways that patients describe these. You can find it in arthritic joints, fractures. If someone has an abscess, we'll talk about the pain that they're having in a somatic way, and it's aching, throbbing, stabbing, pressure. So visceral pain, we're talking about like stretching of visceral organs like the capsule of the liver, linings, activation of the nociceptors in the linings of the serosa or organs will cause this type of pain, and it can be very difficult to localize. So they could say stuff like deep pressure, it's cramping, and it's spasms, squeezing. Someone who has bowel pain, a lot of spasms and cramping is what they will describe. Let's see, neuropathic pain. We have the continuous that I talked about, so burning and electrical sensations that comes with that, and then the paroxysmal lancinating, where you have sharp shooting, stabbing, knife-like type of pain. And do you guys, you guys understand the reason why it's really important to know the different types, because we're going to treat them with different medicines. Or we may treat all of them with opioids, but we have other medicines that can help make those opioids more effective by treating the type of pain as well. So we're going to go back to our case now. JK receives 4 milligrams of IV morphine, and that's within 10 minutes, and reports that, so 10 minutes later she reports that her pain has improved. It's 8 out of 10, so it's still bad, but now she is able to talk to you and allow you to complete your examination. And we do a whole examination, but I'm going to only talk about one point, is that your examination does reveal that she has point tenderness of the L1 through 4 vertebrae and left lower extremity weakness. So let's do question 2. What is the next step in treating JK's pain crisis? And I want you to choose all that apply. I'm going to let you guys read them for a minute, and then you can go in here to tell you what the consensus is. Whenever you're ready, you guys tell me. What do you think? B and C.
And D.
Exactly. And maybe D. Yeah, so definitely B and C. Right? Maybe D. And then A might still need a little more time. You might need to get her pain under a little better control first. But right now you need to deal with the physical pain. So we say B and C. D could be in there as well, but the reason I say that D is not there is because first you're gonna do these other things, and you will get XRT because you have worries. You're starting the steroids because you're worried that there could be spinal cord compression from a metastatic lesion. But you're really gonna do these things first. You're gonna order pain meds and that, and then you can go and talk to XRT and set all of that stuff up. But before you call them, you want to have her on the steroids. Okay. So the pearls from this question are the best initial approach is to treat a pain crisis with rapid titration of IV opioids. It can be done subcutaneously or orally if that's the only route you have. Morphine IV is short acting, and you can see this is straight from your pain card. Its onset of action is 5 to 10 minutes. Its peak effect is 10 to 20 minutes, so it can be rapidly titrated every 30 minutes. And as her pain remains 8 out of 10, severe pain, which is considered severe pain, one would increase the dose by 50 to 100%. So you would actually increase her IV morphine dose to 6 to 8 milligrams IV, and then check for how she responds to that dose after her first dose. Go from there. Okay? It's also important to recognize or rule out metastatic disease causing spinal cord compression and treat if there is a reasonable suspicion that spinal cord compression exists. Anybody have questions about that at all? And these are the incorrect answers. A, we're just gonna wait a little bit longer, and then D, for the same reasons I said. You are gonna do it, it's gonna be in your steps, but it's not gonna be your first step. Okay. It definitely should be there in your mind, or on your list of things. Case 1 continued. Does someone wanna read at all? Let's have somebody volunteer.
Next day when you visit JK, your left low back pain and hip pain is better controlled at a rate of 6 to 7/10 on an IV morphine PCA with 8 milligrams per hour basal rate and 8 milligrams Q10 minutes demand dose. She continues to push the button for demand dose almost 3 times an hour. She's used 432 milligrams in the last 24 hours.
And that's just a
And that's the
calculation of how you
calculation
came up to that. So she used 8, she had 8 milligrams of the basal times 24 hours, that's 192, and then she had 30 demands, which was 8 milligrams, that added up to 240. And then you add those together to come to 432.
She expresses concern to you about jerky movements in her arms and legs that started yesterday evening and seems to be worsening. These movements are disconcerting and interfering with her sleep. You witness one of the jerky movements while in the room.
What are you guys thinking about the jerky movements? Okay, so what's your next step? Choose all that apply. So you recognize the jerky movements as a side effect of opioid medication called myoclonus and decide to rotate JK to a new opioid medication. Sounds like you guys already said yes to that. You tell her that it's irritating to be experiencing these jerky movements, but you don't want to make changes because we finally got some progress in treating her pain. You decide that an oral opioid regimen with morphine, transition to oral opioid, and saying that she's reached her limit of tolerability with IV, or you decide to transition JK to an oral opioid regimen and rotate to a different opioid medication because of the myoclonus. What do you guys think? A and D. Oh, sorry, just A. Wait, did I not read it right?
D looks the same as A.
Yeah, I think.
Transition her to oral.
Oh, but we're not transitioning to oral yet.
Oh,
That's
okay.
where we're
Yeah,
catching
that's
ourselves
nice.
up, because her pain is not well enough
It's not
controlled
controlled
yet.
enough.
Exactly. Good catch.
And also in acute crisis, you don't switch to oral.
Exactly. You want the pain under better control before you switch to oral medicines. Definitely. So, correct answer is A. So the pearls from this question are that myoclonus is sudden jerky movements of one or more muscles. Myoclonus is a sign of encephalopathy and may occur alone or may be associated with somnolence or mental clouding. And it is a side effect of opioid medications that will often resolve with rotation to another opioid. Okay? The incorrect answers are, I want to point out that that you can decide to not transition to another opioid if someone has myoclonus if it's not bothering them. So if it's bothersome, that's when you should be definitely rotating. If it's bothersome to you or other people, then you can also decide to rotate. But if a patient's saying, it's not bothering me, and I do not want to mess with my medicines, please, I just wanted to let you know, just in case I had to worry about it, then it's okay to stay on that. But if it starts getting worse, then you may want to consider rotating them.
But it was interrupting her sleep.
Exactly, and she said, it's bothering, this is bothering me, so. And then it is, if you can't rotate to another opioid for whatever reason, maybe they're allergic to everything else, then you can try and decrease the dose by 25% and see if that takes care of it. Or you can treat with benzodiazepine or anticonvulsant or baclofen. Those are ways to treat through that myoclonus.
Is that a transitory symptom or a side effect?
I don't think it really is. It could be, but I think it will stay usually, unless you go down. So it has to do with the buildup of metabolites. It's got the same dose, those metabolites will probably still be there. Okay, so, and then for C and D, it's incorrect because quickly needs to be better controlled, is the point. So, I caught myself on that here. In front of you guys, oh no. Anyway, that's okay. So common opioid side effects. This is a good point to go over. They're all on your card. I have them listed here. It's important to realize that you can treat through most side effects of opioids, and that they will go away over time. Constipation is the one that does not. Myoclonus, it may not, but you definitely won't be able to just ignore the constipation. Once they have it, they're likely to continue to have it, and the truth is you should probably, instead of waiting until they have it, you should be preventing it. So if they get an opioid, they get a bowel regimen as well.
What's the contraindication to initiating the bowel regimen?
Well, they have an allergy to it, yeah.
They're obstructed or?
There can be some people that have, extreme reactions to them. They say they're allergic to them. I don't know that I've ever had, has anybody had a true contraindication to a bowel regimen?
They're infected. If
Diarrhea?
you don't want to, it's for a laxative,
If they're,
you have a bowel perforation or something like that.
So when you're already constipated beforehand, starting opioids, you need to investigate why.
That's the most common.
What's that?
Diarrhea.
Yeah. Well, diarrhea would be a contraindication. There you go. That's a
That could be a
real
sign of
easy one.
infection too.
Most common instruction.
Yes.
Is that sodium or potassium?
Either one.
You could use either one.
So if it's sodium, would you use like 200 instead of the regular?
Well,
Usually the sodium is 240.
is it,
But it's a calcium, but the calcium is not that stable.
Is it?
yeah, I don't know
One
which
of
one's
them's
which.
100.
We only
so-
have one at university.
Oh, is
so
it?
It's the 240.
I got
whatever that
the
is. Yeah, so, but in general, I mean, these are over-the-counter medicines, and a lot of, if you're treating someone as an outpatient, you do need to, even if it's an over-the-counter medicine and you don't need to write them a prescription, I recommend writing it down, whether it's on a prescription or not, saying it's over-the-counter, you need to get this, because if you don't do that, they quickly forget, and they'll just wait till they're constipated, and then you'll have mad patients coming back, and you're like, I have never taken these medicines in time. And then you have a hard time because they have pain and you're trying to treat pain and they don't want to take the medicine. So let's go on to the rules for opioid conversion. This is important. This is on your sheet somewhere, but you want to calculate your 24-hour total dose used. So the last 24 hours. For all conversions, they're based on the oral morphine equivalent, which I said earlier. Remember to decrease by 25 to 50% for cross tolerance when converting to a different opioid. Very important to remember, because you don't want. Do you guys understand the reason for that? Why when someone's on an opioid, they develop tolerance to that opioid, but another opioid they may be very naive to, and they can have a much quicker and faster response, just like they did when they first ever had an opioid, like an opioid naive patient. So you want to take into account for that when you're switching to another opioid. They may tolerate morphine really well, but they get to Laudin, and it's like they've never had it, obviously. And they have it. Just because it's an opioid they're not exactly the same. Okay.
And that means, like, even if this patient was opioid naive and she'd only done morphine for 24 hours, you still do the decrease?
If you're going to a different opioid.
Okay.
So if
So
you're
it's
going
any-
from
you can
IV
develop
to
that
PO,
cross tolerance.
they're in the same opioid, you do not have to do cross tolerance.
Okay.
Only if you're changing from morphine to Dilaudid or whatever other opioid you're changing to. But if they're on, let's say they're on 2 opioids, they've been chronically on hydrocodone, and in the hospital they were getting IV morphine, but they haven't used that much, you want to go back to the hydrocodone, and they've been getting it PRN, so that you don't need to do cross tolerance in that if they're still getting it. If they had it very recently, you don't have to. They're still tolerating it, is the point. And then, so number 4, uncontrolled pain, moderate to severe, equals increased 24-hour total dose by 50 to 100%. So if they have moderate to severe pain, you need to consider increasing it. So there are times when you're not doing cross tolerance just because they're in severe pain still, they're going to another opioid because they're having side effects, they're still in severe pain. And so you may decrease by 50% for cross tolerance, but then you're increasing by 50% or maybe even more, 100%, for severe pain. So there are times when you're not really decreasing as well. But that should be the clinical judgment that you're doing, and you should probably like document it. For inpatients, you should be documenting that, because if you're a consultant, they want to understand. They don't want to be scared of what you're doing. They want to see that, hey, we have reasons for what we're doing. We're not just pulling numbers like they, I don't know, in medicine as a resident, we just pulled numbers. We're like, oh, well, let's try 2 milligrams of morphine. This person probably can tolerate that. There was no rhyme or reason why we chose anything, okay? So it helps them to understand, especially when you're getting into the big numbers like our case. 8 milligrams of morphine, basal plus, that's a lot of morphine. And so in order for them to follow your recommendations, you really should give some reasoning so they feel like, oh, this person knows what they're talking about, okay? And over time, maybe you don't have to do that as much because they know you. But even then, I think they learn from that as well. And we want to teach everybody pain management because we know that it's lacking in the healthcare community, that there's just not enough teaching for pain management. So, I'm starting to talk too much. Okay, so breakthrough dose should be approximately 10% of the total daily dose. That's important to know because you're always going to have a long-acting. Once you get pain control, then your goal is to have a long-acting pain medicine and a short-acting for breakthrough, okay? You want to take out some of the hills and just like if you're thinking about diabetes and you're talking about insulin, you want to take out some of the ups and downs. You want to have a more level, stable level of pain, and the long-acting will do that. The short-acting is for when they went on a hike with their, grandkid, or, they overdid it that day, or just every day they have to do a couple things, and during that time it increases their pain, so they can have a breakthrough dose. For moderate pain, titrate at least every 24 hours. For severe pain, you want to titrate more frequently, like every 2 hours. Sometimes if you're there at the bedside, you can titrate per dose, because you're there reevaluating and making the clinical decisions to do that. And with elderly, start low, titrate slow, and half normal starting dose. So if you would start there are starting doses on this chart. For me, they come straight from the literature, and I have to say, even as a pain management doctor, a lot of times I start lower than these on just the regular patient, normal patients that I'm not worried about. They're not elderly and they're not opioid naive necessarily. And I don't start at a 10 milligram IV the first time, because I'm right there and I can, IV, you can give them a dose and 8 to 10 minutes later you can decide it's not enough. You can get it, but you have to take the time. So you can use, these are good starting doses, but for me I am a little more conservative, and I just want to let you guys know that. Okay, so JK has used 432 milligrams of IV morphine by PCA in the last 24 hours. We want to, since we have the myoclonus, we want to convert JK to hydromorphone PCA. So we don't have the tables and all that. I would like to have that. We don't. Do you guys want to, does someone want to use the board, or you guys just want to kind of figure it out on your own? Like, who whispered that? You whispered on the board. Anyway, so I'll give you a couple minutes to figure it out. So the first thing you're going to do is convert to oral morphine. multiply by 3 to get from IV to PO. Okay, so your calculation would be the 432 times 3 times 1296 of PO morphine 24-hour equivalent. And that's the most important thing you know. You went to morphine PO equivalent, and then you're going to divide by 20 to get to the IV hydromorphone. And where that 20 came from on that chart?
30
You see how it came from
1.5.
that? What's that?
30 divided by 1.5.
Right, there's 30, it would be 30 and 1.5, so we skipped a step. But I want to make sure it's clear. Your ratio is 30 and 1.5, that adds 20, okay? Do you guys understand that?
30 is oral dose.
Because you always have to go to oral first.
Exactly,
You have to
because
go
we're at
oral
oral
first.
right up here at 1296 to the PO
Oh, right,
morphine, the
okay,
oral
yeah.
equivalent. Okay,
Right.
and then, okay, so then, we are at 65 of IV hydromorphone in 24 hours, okay? We want to decrease by 25% for cross tolerance. And that will give you 50 milligrams IV hydromorphone for 24 hours. So you want to go to your, then you decide that you're going to do a PCA, so you're going to give them a basal rate, because you don't want them to have to press the, you know how much they need. You don't want to have them press the button to get the 50 milligrams. They're like every 10 minutes. Can you imagine, I mean, when your pain's out of control, it's great to have it every 10 minutes, but can you imagine to have to, for 24 hours, have to press it every 10 minutes to get your pain control? We've had patients that have to do that. They have to press, you know, like, that's just not appropriate. So you give them a basal, because you know what they can tolerate, what they've already tolerated. If you were starting on a PCA, you don't give a basal. I just want to make that real clear, because you don't know what they're going to tolerate, and that's what keeps the PCA very safe for a patient. We know what they're going to tolerate, so we can give them what they tolerated, what they've already used, and then they can get more, and it keeps it safe for them, because if they get sleepy, they're not going to press their button, right? And that's the reason you use a PCA, is because they're using a lot of big doses, they can press the button and get quicker relief, and you're going to be very safe, okay? So you're going to give them 2 milligram basal rate an hour, and then you can have a 2 milligram Q10 minute demand dose. And we do the Q10 minute because we know that, if you look at your card, that you should have your effect, okay? That, if they press it again at 10 minutes, then they need more, because they're having their peak, that's the peak effect that they're gonna get. It's not gonna get any better, so they need to press it, okay? And then you can, I mean, some people may choose to keep 15 minutes, because we say, this is ranges, it's what you're, no problem. But anyway, so you want, you know, you can choose if you're 8 minutes or 15 minutes or 10 in between. That's just kind of a clinical thing, because we're not really exactly sure, but it's going to be pretty safe if you do somewhere in there. So if pain is uncontrolled, you may not decrease, this is something we talked about earlier, you may not need to decrease the dose, and you may increase it by 20 to 50%, like we talked about earlier. Because you did the cross tolerance, but you're canceling that out because they have severe pain. Okay. All right, so let's go on with the case. JK has transitioned, so he's now on the hydromorphone PCA. The next morning, his left low back pain and hip pain is still at a 6 out of 10, but she's much happier. The jerky movements are gone, and but she does have some burning and shooting pain that travels from her hip down her leg. The MRI showed that there's multiple new metastatic bone lesions along her L spine with possible spinal cord compression. There's also a new bony met in the left acetabulum. Okay. The primary team has consulted neurosurgery and radiation oncology. JK has refused surgical intervention and wants a more non-invasive approach with XRT, and the first treatment's already scheduled today. The primary team would like to discharge JK in the morning with a plan for outpatient radiation and continued follow-up in the outpatient palliative medicine clinic for pain control. So they're ready to send her home. She already has a plan, and her pain's not great control, but it's better, and she's much happier. So what are we going to do now? What additional medicines can we add in? Right, so we're talking about adjuvant medicines, right? Is this the wrong slide? We're missing a few days there.
Yeah.
I'm sorry, I was up to 1 o'clock. So gabapentin is a great choice. We do know that she has bony mets. So we also want to, think about what else should we be doing for her? So bisphosphonate, that could help with pain control. Naproxen is great for bony mets, right? And methadone, I mean, maybe right now we don't want to change to methadone, or maybe we do, because we're going to go to an oral regimen, right? And so that would be a good choice because it has the NMDA receptor blockers in it, and so that could help for the neuropathic component of the pain. And then Christy, pain. She's done dealing with this pain. No. So our correct answers are A, B, and C. Okay. Somewhere down the line, the IV lidocaine might actually come into play and be the appropriate choice, but not quite yet. Let's see. Okay, so our pearls, consider, would you like to tell me the answer? We've been working on this, because we have another course coming up. So addition of adjuvant when treating pain, you want to consider that. And then bone pain, when you have bone pain, you want to do an NSAID, bisphosphonate. And then for neuropathic pain, consider anticonvulsants, sodium channel blockers, and NMDA inhibitors, okay? So our analgesic adjuvants, what are they? I think you guys know these really well. I don't know that we need to spend a lot of time on them, but I wanted to make sure you're thinking of not just Tylenol and NSAIDs and the neuropathic medicines, but also non-pharmacologic adjuvants, because they can make a big difference. So relaxation, acupuncture, tendons, massage, hot and cold packs. I mean, we have a patient that's on a huge amount of Dilaudid, and the things that help her the most are the gabapentin, the NSAID, and those are medicines, but then also the hot packs is the other thing. Like, I couldn't live without that. It's like, oh, who cares about the Dilaudid? Well, you use 60 milligrams, it's a big deal. Just like, but that doesn't help as much, So the point is that you got to think of these other things because they could help even more than your opioids. Not saying that that person that I'm talking about could live without the opioids, because she should be crying, screaming in pain. But once the opioids are at their effect, these other things help so much more that makes life tolerable again. So question 5, JK has used a large 24-hour amount of IV hydromorphone. What outpatient opioid would be a good choice for her? So let's choose all that apply. So morphine extended release, long acting, what do you think? Probably not. She had the myoclonus on morphine. So. Morphine immediate release, same thing. And then methadone for long-acting pain control, I would choose that. And what about oxycodone or hydromorphone oral for PRN breakthrough pain control?
Sounds good.
I would do that. So maybe C and D are going to be your regimen, okay? All right, so there's your answers. And so methadone is a good choice for long-acting oral control with someone who uses high-dose IV opioids, because they can have a reasonable dose to take to control their pain. You do have to be careful with methadone and get comfortable using it, so you need to be working with other people to get comfortable, and then you'll be okay on your own. Understand the pharmacodynamics and all of that. So to achieve good pain control, long-acting and short-acting opioids should be steroids. So those are our major points. And then our incorrect answers really is the myoclonus, which we kind of talked about. Okay, so methadone has long and variable half-life, 6 to 190 hours, can lead to sedation, confusion, respiratory depression. Always write hold for sedation when you're prescribing it. When converting from oral to IV, you reduce the total daily by 50%. And this is oral methadone, IV methadone, oral methadone to IV methadone, okay? You're not changing to a different opioid, you're just changing the route. And then when converting IV to oral, you use a 1-to-1 conversion. And that's important to remember, don't switch that the other way around. It blocks the NMDA receptors, which increases analgesia and may reverse tolerance. And with someone who's on a PCA of like IV Dilaudid with a large amount, this is an important thing to note. And that's why we can't just use our regular conversions. We have special charts and other things out there, which we're gonna go over a couple methods real quick. Because it increases the pain and it reverses tolerance, then if you have someone on a huge dose, they may be very tolerant to Dilaudid, but not only are they going to be not tolerant to methadone because it's new to them, but also it can reverse some of the tolerance just in general for opioids. So you want to be very careful with it. In moderate to high doses, greater than 100 milligrams a day, it can cause QTC prolongation, so you want to consider getting an EKG baseline and monitoring when you do dose changes. Okay. There's, it's just minimal evidence with this, but you just still want to be really careful. And it's usually just anything that's ever happened, it's been high doses. So you can feel a little bit safer if you're using low doses without getting EKGs and all of that. Especially in palliative patients and elderly patients, you want to be even more careful. Okay, with the methadone. So there are meds that interfere with methadone metabolism, and that's through the P450. So these medicines, there's medicines that reduce levels and increase levels. It's important to know that because you could have some interactions. With that. So when you're doing methadone rotation, this chart is actually on your pain card, so you have it. This is what I usually use most of the time. This is a modified version of what's in the Unipack, but it works really good. So if they're less than 1,000 milligrams a day and less than 65 years old, then a 10-to-1 oral morphine equivalent, oral 24-hour, to oral methadone, it's 10-to-1 ratio. Okay. So you'll be dividing by 10 whatever the oral morphine equivalent is on those lists. And then if they're greater than 65, you want to do a 20-to-1 ratio. If they're on a large amount of the oral morphine, like 1,000, 2,000 milligrams, any age, you want to use a 20-to-1 ratio. And then greater than 2,000 milligrams in a day, you may want to do, I do the 30-to-1. On your card, it'll say, may consider a 30-to-1 ratio. And then, but the point is that usually if I'm here, I use another method but it takes inpatient most of the time. It's not as easy to do outpatient, although it can. So this is another way you can do methadone rotation. So on your day one, you decrease the previous dose of the opioid by 1/3. So whatever they were on, you go down 1/3, and you replace it with 3% of the previous dose. Okay, so there's an example here, and that helps. 1,000 milligrams of oral morphine is their total daily dose as an outpatient. And so you're decreasing that, so they're going to get 660 milligrams for their total daily dose. That'll be divided into how many times a day, but that's where you're at. And then they would get 660 milligrams of PO morphine, let's say they got in the day, and then 30 milligrams of methadone. And remember, you're dividing that into TID dosing, so 10 milligrams TID. Okay. On day two, you decrease by another 1/3, but you don't increase the methadone unless there's moderate to severe pain. So let's say that the pain is, that they're saying it's not severe, that it's mild, and so you would decrease to 330 of the morphine for the total daily dose, which may be like 110 TID, and then you continue with the methadone 10 TID. And then you do need to make sure that they have PR and breakthrough short-acting opioid if they have breakthrough pain. Okay. On day 3, you can discontinue the final 1/3 and continue the PR and breakthrough at 10% the total dose of methadone. Okay. So where are we at on time? I don't know if we have time for this a second.
Yes, 5 minutes.
Yeah, okay. So there is another case. It's got some really good learning points, so I encourage you guys to go through it. We don't have time today, and it has more questions, but there are some things that you just in general need to know. And so what do you need to know about opioids and renal insufficiency? These are important things to know. But morphine has a metabolite, and the more potent It is a more potent analgesic, so it's an active metabolite. And so it may accumulate and cause more sedation, okay? Hydromorphone also has a metabolite that's inactive, so it does not help with pain control at all, but it does cause CNS toxicity that builds up. So with hydromorphone, you have to be very careful with patients on dialysis. But you can use it because on dialysis, you just have to be careful. And you have to avoid it in the patients with a GFR less than 30, okay? Important pill. What about liver problems, patients with liver problems? With morphine, you have an increased first pass metabolism and a delayed clearance. So we recommend that you decrease the frequency of administration and the dosage. And then if they have concomitant renal failure, you also want to avoid secondary to the accumulation of the hydrophilic metabolites. So if they have renal failure and liver failure, morphine is not your choice. Okay.
Well, how about methadone?
Methadone is the one medicine that you can use in renal and liver. Actually, there's another one too, fentanyl. And that's in the second case. You guys, you would have learned that, I'm sorry, we just didn't have enough time. But I will be happy to send you guys this information so you can go over it, because it's good information, and for you fellows, it's great for your boards. And then when you do the board review course, you don't have to come to our workshop, other people can come, because you already got it. And then, but also with hydromorphone, when someone has liver insufficiency, it lacks toxic metabolites. There is a risk of accumulation of the parent drug, in other words. So the same thing that you should decrease the dose by 50% of the usual amount and use prolonged interval dosing. And so that's something you have to kind of adjust for the patient. So you may start at, instead of every 4 hours like you normally would do, you may want to start at every 6 hours and see how they do. And, you know, if they're running, if their pain's coming back in between their dosing, then you may be able to move it up, and maybe they're clearing it better, and they could get it every 4 hours, but you just want to be careful to start with, okay? And that's one of the reasons why PRN works when you're treating acute pain, because they can ask for it when they're ready for it, and then you know what the dosing, what they really need, okay? Okay, so this is where we're going to convert to fentanyl, but we're not going to do that because we're not doing this case. Sorry, guys. So when a patient is no longer able to receive an oral medication for pain management, transition to sublingual, I want to just mention this, it's important. Subcutaneous, rectal, IV formulations are appropriate, and fentanyl can be one of those choices. The important thing to remember about fentanyl, just in general, is that they should have tolerated an oral or IV. They should have tolerated a certain amount of opioid before you put on the patch. You just don't put on a patch for somebody because we don't know if they'll tolerate it. And for fentanyl, if they need to tolerate it, but per the books, it's 60 milligrams of oral morphine equivalent in a day, and they say over 3 days is what it actually says. I usually go with 50 milligrams because I do the 2-to-1 ratio. So if they can tolerate 50 milligrams of morphine in a day, oral morphine, then I give them a 25 mite patch. And they would do that. So, but you know, you do want to consider 1 day. You know, can you do that in 1 day? You can, but you need to be a little. You know, you may want to be cautious because they do say over 3 days that they should tolerate that dose. Okay, so. We're at the end of our session, and so I just want to see about, is there questions? I know you guys are like dying of heat. We need like a fan, that's what we'll have to, for the next one, right there in the doorway. No, I'm just kidding. Any questions?
So going back to that start slow and go low with the senior, now if she were 75, you know, this first case, where would you start her at, that morphine dose?
You know, I think it would be safe to do like a 2 milligram IV morphine dose to start out, see how she tolerates it. You can even start at 1 milligram. That's because in 10 minutes you can give more, you know, so it doesn't hurt. As long as you have the time and are willing to make sure you're taking care of that patient, There's no reason why you can't start low with just about anybody, but you're standing there 10 minutes, you know, you're checking, or the nurse is checking in 10 minutes later to make sure that that's gonna be a accurate dose, because in 10 minutes, if they're still in pain, they need a bigger dose.
But in the handout, they say that for the PCA, for elderly, it has to be bolus first, then basal.
For everybody, always. Bolus, no.
Well,
Demand
you
first?
can do it that way,
Okay.
right?
You mean if they can't?
He's saying that
Probably
because
don't
it
know what
says consider, starting with a demand bolus only, instead of just putting the basal on if you have an elderly or frail, and that's what Dr. Jones said
Everybody should
earlier.
be doing that. I think not just elderly, everybody, you should start with the demand. You can give them a demand and go back in a half an hour and see if they pressed it every single time, and say, well, calculate what that is, times it by 2, and say every hour they can tolerate this dose, or close to it, even if you don't times it by 2, and then put a basal on. But you should always let them, if you want it to be really safe, you need to let them press the button and pick it can be a short amount of time, an hour, 2 hours, and see how much they use, and then add a basal in, because you don't know what they're gonna tolerate until they start getting it. And if you do a basal and you turn it on and you leave, and it may be low, 0.5 milligrams an hour, but you leave, but that means that they are getting 12 milligrams without ever pressing the button. You leave, they may be knocked out. And you're like, okay, now we have altered mental status to deal with. So I recommend for everybody, unless they've been on opioids the day before and you have something to go with, always start. If their pain is severe enough and you're planning on doing a PCA, that you're going to start with demand, and then quickly, you don't have to wait a whole 24 hours, but quickly change to a basal and demand. Okay? All right, guys, well, thank you for studying with me. I would be happy if anybody gives me their email or just their name. We're all close. Email address, I'll be happy to email the actual presentation to you.
All right, thank you everyone for coming to today's grand round. Who here has not signed in? Today we'll be getting an evaluation from me through email, so please complete it and submit it. It's beneficial for Dr. Healy, the GREC, and for UTHSCA, all the same. So once you get it, please complete it. And thank you.